welcome to today's channel. My name is Kemi, and right now I just want to do a review on renal pathology for 1 hour before I go ahead to sleep. It's been a really long day, so let's see how it goes. So let's see how it goes. Okay, let's get started. Hi, just doing a review. So I'm starting with pathology diagnostic, and we have primary disease, secondary disease. And for the primary disease, they are the disease that originate from the kidney, that's from the renal tissue itself. And we have examples as minimal change disease. Minimal change disease is common to kids, and we have for adults focal segmented glomerular sclerosis or IgA nephropathy. Now for the secondary disease, we have these are diseases that cause damage to the kidney from structures, from systemic process. So they would cause damage to the kidney from systemic process. Okay, hi Yorubawa, thank you for joining me. And example will be diabetic nephropathy or lupus or even amyloids. Amyloids are issues with protein folding. Now we have some diseases that they have focal involvement, meaning that they focus on one path, and that example is FSGS, which is focal segmented glomerulonephritides. It's like a 50-50 glomerular involved, so it takes a part of the glomerulus and focused on that part we have issues, not the entire glomerulus. And we have the diffuse involvement, which would do more than 50% of the glomerulus to be affected. And for this we have diffuse proliferative glomerulonephritis. Okay, now we also have some that deal with the membrane, like the thickening of the collagen, the glomeruli basement membrane, and they come without any inflation. Hi everyone, thank you for joining me tonight. I'm studying for renal pathology for USMLE. So if you're a student and you're joining me, please give the video a thumbs up and make sure to subscribe and encourage me on this journey of becoming a medical doctor. And so I'm looking at, there are some that are proliferative, meaning that they spread to the mesangial, and they increase the number of glomeruli cells. Example will be post-streptococcal or even diffuse proliferative glomerulonephritis. The names are just I need to sleep, is after 11. Okay, and then we have some that form crescents, like the rapid progressive GN, or some even form sclerosis and some form necrosis. Okay, so those are the pathology diagnoses. I will go on to the urine analysis for knowing what the patient is having. Urine analysis involve doing two things. One is to do microscopic, look under the microscope if you can see anything, and the other will be to use the urine dipstick. Now for gross examination, if you see a clear or yellow under gross examination, then that is normal. But if it is dark brown, we're looking at acute tubular necrosis. Or if it is red or pink or cola color, then there might be hematuria, that's blood in the urine, or maybe the person just had beets, BEETS, or even medication like ribampin could give the urine pink, or red or dark color. Then we have dark brown. This is due to liver diseases or presence of bilirubin in the urine. When it's black, then it's alkalonuria. Has to do with thyroidism, enzyme deficiency, and this is high yield. So when you have black urine under gross examination, it's due to alkalonuria, and this is high yield. Okay, and it's possible to have cloudy. This shows the presence of white blood cells or neutrophils in the urine, or even pyuria, which is dead white blood cells. If there is a odor like sweet smell when you pee, that could be due to maple syrup urine disease or even ketoacidosis. Okay, or if it is musty, then is pyelonephritis. Okay, let's talk about the urine dipstick. The dipstick shows the presence of substance because that's different colors. I wish I have one here. Has different colors, and when you dip it in the urine, you match it to the colors on the container to know what the patient is having. And of course, we have urine sediments that can be used for urine analysis. That will be the presence of stones like RBC stones. Hi, how are you doing? Where are you joining from? Thank you for sending hello. Hi. So we're talking about casts like RBC cast and all the other casts we could have. Shortly, we'll talk about the cast. So we have fatty cast, which is the first one, and this the buzzword to look for is when they say it has Maltese cross. It's like a cross sign, but instead of just a cross, it's like that's in 4 places. So like Maltese cross, that shows fatty cast and is associated with nephrotic syndrome. Nephrotic syndrome is when you have high protein in the urine and lipiduria, that's lipid in the urine. We also have granular cast. This one will give you muddy brown appearance, and that is common when the patient has acute tubular necrosis. Okay, that is cellular injury leading to necrosis. We do have another cast called the Eileen cast. Now, Eileen cast is seen in healthy people, and like if you're healthy, you might have Eileen cast in your urine if you are dehydrated, or maybe you just add rigorous exercise. Your urine can contain Eileen cast, and it's a tried for term phosphoprotein THP. We do have RBC cast, which shows the presence of blood cells in your urine. That's hematuria. It's common in post-streptococcal GN, that's glomerulonephritis or lupus. Okay, it means the glomerula is bleeding and the disruption of the glomerular membrane. When you see white WBC, which is white blood white blood cells cast in the urine, it's in this one is not common. You will see it in patients that have transplant rejection. White blood cast is a triad for transplant rejection, maybe kidney transplant, and it's been rejected, or the patient is having acute kidney stones, that's pyelonephritis, or acute interstitial nephritis, AIN. Inflammation of the renal stone. Okay, then the last one will be the wasicast, and this is like seen in chronic kidney disease or early stage renal disease. It means the kidney is damaged or there are presence of reduction in kidney function, renal stasis. Sorry, my phone distracted me. Okay, so to recap, urinary cast are seen in the urine, and we have 6 types. Fatty cross is presence of Maltese cross in the urine and is common in nephrotic syndrome. Granular cast is muddy brown appearance of urine, which is common in acute tubular necrosis. Hyaline cast is termed Osman protein secreted by the tubular epithelial cell, and it can be seen in elderly people if they are dehydrated or they just finished some rigorous exercise. We do have the RBC cast, which shows hematuria, bleeding of the glomerula, and we have WBC cast, which is common to transplant rejection or acute interstitial nephritis or even pyelonephritis. Lastly, we have the waxy cast. This shows that chronic kidney disease or any early stage renal disease, presence of renal stone or even kidney damage. Now let's go to, oh, why are you doing this to me? Let's go to nephrotic syndrome. Nephrotic syndrome, like I said, a common cast you find is fatty cross, Maltese cross, which is fatty cast, okay? So for nephrotic syndrome, there is increase in protein, so there'll be, the symptoms will be proteinuria that is greater than 3.5, and this is due to podocyte effacement. They lose their negative charge, therefore proteins can slip through. Proteins like albumin can slip through, and because of that you have increased protein in the urine. It would also lead to edema, and the urine proteinuria will be greater than 3.5 when measured in a day. Collection of urine 24 hours greater than 3.5 grams of protein in it. Excuse me. And that's for nephrotic syndrome. On the other hand, nephritic syndrome shows dysmorphic RBC cast, and it also has to do with damage to the glomeruli. But in this case, you find RBC cast, the patient will present with hypertension. There will be edema, swelling, but to be mild. And the protein content will also be lower than 3.5. So the major thing is nephrotic, the protein content is greater than 3.5 grams per day. In nephritic is lower than 3.5 grams per day. Nephrotic, you will have lipiduria, there will be lipid in the urine. In nephritic, there will be hypertension, hematuria, which is blood in urine, and GFR will be reduced. Yeah, I think we covered that. I feel so sleepy. Now let's go to examples of pathology of nephrotic syndrome. We have 5. We'll do that 5 now. If there's still time, we do for nephritic syndrome, then we call it a night. So the first one for nephrotic syndrome. Remember, nephrotic has to do with proteinuria greater than 3.5, lipiduria. Okay, those two things, like they are the most common. There will be edema, which is swelling, and there will be frothy urine. Okay, frothy urine. So the first one I'm going to be talking about is minimal change disease. As the name connotes, there is minimal change in the podocyte foot process. Okay, so just little effacement. All right, and this is due to immune dysregulation. So there will be an increase in cytokine production for T4 cells, and the leading to podocyte effacement, therefore loss of negative charge. There will be selective proteinuria, meaning that only a few protein can pass through. Because the effacement is still little, only albumin will be able to pass through. To diagnose, when you look under the light microscope, you don't see anything. However, under the electron microscope, we will see effacement of the foot podocyte process. Under immunofluorescence, there will be no immune complex deposition. Okay, to manage this, high yield is to use glucocorticoids. Glucocorticoids are used to manage minimal change disease, and the prognosis is good because this happen in kids. They'll be able to heal fast, 90% prognosis, which is good. Okay, association, this is common in children. Minimal change disease is common in children, and is idiopathic in the sense that we don't really know what caused it. However, it can happen after upper respiratory infection, or after immunization, or some medications like NSAIDs. These are pain medication. They could cause effacement of the podocyte foot process. Hi everyone, thank you for joining me tonight. My name is Kemi, and I'm just studying for renal exam. If you're a student, you can join me and let us study together every day. That would be so good. If not, just subscribe to the channel and join my story as I get ready to be a medical doctor. Thank you. So, nephrotic range, the protein will be greater than 3.5, lipiduria, frothy urine, edema, and protein to creatinine ratio will be 3.5 ratio 1. Okay, makes sense. That's minimal change disease, which is common in kids. Now, there's another one that is nephrotic syndrome and common in adults. That is a focal segmented glomerulosclerosis. So focal segmented is FSGS. This one causes damage to the filtration barrier of the glomeruli, okay, therefore leading to sclerosis. And it's common to adults. Under the light microscope, you'll see segmented sclerosis, about 50 to 50. So if this is the glomeruli, about half of it would have the sclerosis, the deadening of the cell. So, and under electron microscope, you would see podocyte effacement. Under immunofluorescence, we'll see deposition of some immune complex like IgM, C1, and C3. To manage it, we can use immunosuppressants and manage the symptoms. It's also idiopathic in nature, just like the minimal change disease, which is common to kids. The FSGS is common to adults, and secondary cause can be HIV, sickle cell disease, heroin use, or common in African and Hispanic descendants. So it's common in, so if they ask a question like, oh, a 52-year-old African male who is positive for HIV and uses heroin is seen to have proteinuria greater than 3.5, some podocyte effacement under electron microscope, and what will be your diagnosis? No hematuria, edema, proteinuria, and lipiduria present. What will be your diagnosis? Because they told us about those secondary causes, and they also mentioned that podocyte effacement under the microscope, we would go for focal segmented glomerular sclerosis, FSGS. The third one we'll be talking about is the membranous nephropathy. When we talk about nephropathy, it means there is no inflammation, okay? So this membranous nephropathy has to do with the thickening of the glomerular membrane. That's damage to the glomerular filtration barrier. Diagnosis will be that it will test for antibodies like anti-PLA2 will be there. Under the light microscope, you see that the collagen 4 of the glomerular basement membrane will be thickened. And under the electron microscope, we'll see spike and dome. This is high yield. So for membranous nephropathy, we'll see spike and dome subepithelial deposits under electron microscope. Under IF, we will see bumpy deposits like this. Bumpy. Okay. This one is associated with solid tumors. Membranous nephropathy is associated with solid tumor, associated with use of NSAIDs. Those are pain medication. Infections like hepatitis B or C could lead to this, and of course, systemic lupus. So we discussed 3 so far. Let's do a recap. We have the minimum change. That is common to kids. The focal segmented GS is common to adults. And then we have the membranous, which has to do with the thickening of the glomerular membrane, associated with solid tumors, lupus or NSAID. It has spike and dome under electron microscope, and it also has bumpy under IF. And that is it for membranous nephropathy. No inflammation. The fourth one is amyloid nephropathy, and this is buildup of extracellular amyloid proteins. It has to do with misfolding of protein, and here they have different types. The primary cause will be AL, plasma cell disorder, which can lead to multiple myeloma. The secondary will be AA, which is chronic inflammation that can lead to rheumatoid arthritis. And we have dialysis related to beta-2 microglobin. Those are the types of amyloid nephropathy. Let's go again. The primary is AL, plasma cell disorder, like multiple myeloma. The secondary is AA, chronic inflammation, like rheumatoid arthritis. And then we have dialysis related, which has to do with beta-2 microglobin. Diagnosis for amyloid nephropathy is that you will see apple green benefit on Congo stain, apple green color on Congo stain. The treatment is that you have to treat the underlying condition while the proteins are not folding well. It's associated to multiple myeloma, rheumatoid arthritis, and dialysis related to beta-2 microglobin is common in elderly patients. So this is elderly patients for amyloid. 2 things I'll take away from this is that it has apple green under the microscope. Under light microscope, you see apple green color. And I'll take away that it's associated with multiple. So when they are telling me this patient is an elderly person with multiple myeloma, rheumatoid arthritis, or beta-2 myoglobin related, and the person has apple green benevolence under the light microscope, I would say amyloid nephropathy. Then the next one would be, which is the last one, is diabetic glomerulonephropathy. This is common in adults, and also has to do with thickening of the glomerular membrane, mesangial cell expansion. So the efferent arteriole is having hyaline sclerosis. Okay, this will increase the glomerular pressure. So it's like this is the afferent, the entrance to the glomerular, and this is the efferent, the exit. So if this exit is having any kind of sclerosis, is constricted, then what is coming in is not going out. Therefore, there'll be an increase in the glomerular pressure. Okay, so that's what diabetic glomerulonephritis does. Increase the pressure. So for this one, the podocyte injury have non-selective proteinuria, meaning that all form of protein can come in, not just albumin. Okay, it's now really damaged for diabetic glomerulonephritis. Under the light microscope, you see thickening of the GBM, you see messenger expansion, and the IUD part is that for diabetic, you see Kinstel-Wilson nodules. Oh, diabetics, we have nodules. Now I remember. Hi, Sita Monster. Hi, thank you for joining me today. I really appreciate that. Thank you. Yeah, so under the light microscope, to recap, we have the thickening of the glomerular membrane, mesangial expansion, and the IUD finding under light microscope is Kimmel-Still-Winson nodules. So when they tell you somebody has diabetic and there's mesangial expansion, there's nodules under the light microscope, just think of diabetic glomerulonephritis. Under the electron microscope, we will see the podocyte foot process effacement. That will now allow for non-selective proteinuria, meaning that all kind of protein can actually come in. And there is no immune complex deposition under the IF. The only one in nephropathy that has immune complex deposition so far is the focal segmented. There we'll see things like IgM, C1 and C3. Minimal, let's do a quick recap of our nephropathy syndrome. Nephrotic syndrome. There are 5. We have the minimal change disease. This is common to kids, okay, and it's idiopathic in origin. We don't know what causes it, but it could be caused by use of NSAIDs, that's pain medication, or immunization, or even upper respiratory infection. Okay, and for this, the protein will be greater than 3.5. There will be lipiduria, there will be frothy edema, and there will be reduced albumin. Then the second one is the focal segmented glomerulonecrosis. And because there's necrosis, it's kind of a 50-50 thing, where half of the glomeruli is actually damaged. Under the light microscope, you see segmented sclerosis and hyaline deposition. So this is IUD. Under the electron, you see the podocyte effacement, and of course there are some immune complex deposition like C1, C3, and IgM. To treat it, we use immunosuppressants like prednisone, and its secondary causes are like adults with HIV or heroin use or even sickle cell disease of African or Hispanic descent are more prone to FSGS. Okay, don't forget, for minimal change disease, we can use glucocorticoids as treatments. Okay, so for both we can use glucocorticoids. Okay, that's good. Now the next one is the membranous nephropathy. For the membranous, remember, is the thickening of the glomerular membrane. Under the light microscope, we see the thickening. Under electron, we see spike and dome. Under IF, we see bumpy deposit. And of course, we can also treat that one too with prednisone, which is a glucocorticoid. Okay, that's like using steroids to treat it. And this membranous is associated with solid tumors. Okay, solid tumor, and NSAIDs, and also lupus. The next one is the amyloid nephropathy, which has to do with misfolding of proteins. It has 3 types. The primary type is due to AL, plasma cell disorder like multiple myeloma. The secondary is due to chronic inflammation like rheumatoid arthritis. And the third is dialysis related, beta 2 microglobulin. When you look at it under the light microscope, amyloid A we have apple green color. Apple green amyloid. Apple green apple amyloid. Okay, and yeah, so it's associated to, so when they ask questions like, oh, this 30-year-old male has multiple myeloma, rheumatoid arthritis, what is the cause? So that would be the cause, amyloid nephropathy. Next, we'll look at diabetic glomerulonephritis, which is the last one for the nephropathy, and this is common in adults. It shows mesangial cell expansion. It is non-selective. So in this case, all protein can go through, not just albumin. Okay, non-selective. Under the electron microscope, you see the podocyte effacement. Under light microscope, you see still wincing nodules. So diabetics is the one with the nodules. And management, we can use ACE inhibitors or angiotensin receptor blocker. That will be the management. Association, it can lead to early stage renal disease if not treated. Is seen in type 1 and type 2 diabetes, and systemic diabetic complication like neuropathy is possible. So remember, management for diabetic glomerulonephropathy would be ACE inhibitor or angiotensin receptor blocker, ARB. Oh my God, to help reduce the glomerular pressure. That is it. Next, I will go to the nephritic syndrome, but I'll do that tomorrow. So thank you so much for joining me to review the nephrotic syndrome of the renal pathology. Join me again tomorrow to review the nephritic syndrome portion. I remain your girl, Oluwakemi, and I'm on a journey to becoming a medical doctor. Mind you, all those reviews are IU'd, and I made my notes using my lecture notes and bootcamp. Thank you.